There are always things we wish we knew before we started our medical practice careers. Not taking the right steps at the outset can cost just time, money, and energy. You know me, I'm always sharing what is most efficient in patient care and practice life. In this video, I'll be sharing the top 5 things a fellow urologist wished she knew before starting practice. And today I'll be sharing an article written by Dr. Damara Kaplan from New Mexico. She was in solo practice, she was in a private practice group, and now she is hospital employed in New Mexico. I will be adding my comments in addition to the AUA News February 2023 article that she wrote regarding the same topic. My name is John Lin. I'm a urologist in Gilbert, Arizona, also your humble host of the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit. It is all for free. And when they say it's free, I say it's for me. Okay, let's start. And let's see. Top 5 things. Firstly, she said the first thing that she wished she knew was how to code properly. And those of you who are in this Facebook group know that I talk about coding and billing. Actually, I help teach some of these topics, and I've given presentations all across the country on proper coding and billing. It is vital for any practice. And I don't care if you are in solo practice, group practice, if you're hospital employed, you have to know coding and billing. You are often not just given, here's a lump sum of money, we're going to pay you no matter what. On the contrary, you are paid based on production. And that production is measured by the things that you do, and how that is measured is by writing down the codes. Unfortunately, I know we spent all these years training, 9, 10 years after college to become urologists, to become APPs, and so that we can take care of patients. Now you're asking us to learn something new that does not really help patients. It doesn't really help with the clinical care of the patient. Unfortunately, if you deal with a third-party payer scheme, it is a scheme and it is a game. You have to play by the rules. And the rules are outlined in ICD-10, CPT, understanding the global period, understanding what is in a global package, understanding modifiers to these CPTs and E&M codes, and learning about work RVUs, total RVUs, practice expense, and things like that. Conversion factor, things that happen outside of your control, such as the legislation from the government dictating how much you are paid, the conversion factor. Understanding all these things will help you practice happier so that you can not just practice medicine. Yes, we all went through training to help patients, but in order to most effectively help our patients, this unfortunately is part of life. If you participate with third-party payer schemes, if you participate taking insurance, if you will. I know a few of you care for patients by directly contracting with the patient using a cash model, cash payment, direct to consumer. You don't have to deal with your insurance. Obviously, that is the best way to go. But for some of you who are in big groups, you need that large volume. And a lot of us take the easy way out. Insurance companies provide a cohort of patients for you to see immediately, and you and I both take the easy way out by contracting with insurance. And if you contract with insurance, the largest among them being Medicare, understanding the rules really will help you. For instance, 99459, the new pelvic examination code, G2211, right? The new codes that are released every year, or changes to the definition of the existing codes. Understanding those will help you with coding and billing, and literally it pays dividends. You think of it as an annuity. You learn these rules, understanding the basics of these rules once, and you build on those rules, kind of like learning medical terminology. I think so much of medical school is learning the language. Same thing with coding and billing, learning the lingo. And then you build on that foundation of the basic language and the lingo, and then you move up from there. And the greater the depth of your understanding and being able to execute and implement these codes, the better it will be for you. There's a reason why some of us practice very happily, feeling like every step we take, we're making strides, we're gaining traction, versus some of us who are constantly feeling like we're spinning this hamster wheel and not going anywhere. All right. So how do you improve your skill set in coding, billing, and understanding this mysterious language? Taking a coding course. Better yet, for me, I needed multiple exposures to coding courses. And even now, I continue to learn. I read the Federal Register, believe it or not, to get to the language, the actual language of how these codes are being, well, legislated, not necessarily interpreted, but legislated. Sometimes the intention is good by the government, by the payers, but implementation and execution is a different situation. And that's why there's some interpretive component to coding and billings. There's some subjectivity, even in something as basic as evaluation and management coding and billing. Literally, in the guidelines, it says the risk section is subjective. The risk when it comes to medical decision making, if you're billing based on medical decision making. So there is some subjectivity, but understanding the basics, knowing what is black and white, if you will, knowing that, and then you can build off of that. It's going to make your life a lot easier. So number one, take some coding courses. And also, of course, if you're watching this, you are in the Thriving Urology Practice Facebook group. So you know we talk about this stuff almost every single day to help you live a happier life, easier life. Other sources, for instance, the American Urologic Association will occasionally have coding courses you can take. PRS Network, also known as the Painters, they also have a resource or multiple resources for you to improve your coding game. CMS, Center for Medicare and Medicaid Services, CMS, also known as Medicare, CMS website. Lots of guidelines. It may not be the easiest to understand, but that's another resource for you to learn about coding and billing. Okay, so that's number one. Number two, learning about negotiating contracts, how to negotiate a contract, knowing your worth as an APP, as a urologist. There are national and local salary data that you can evaluate and use that maybe as a jumping off point to negotiate your contracts. I have seen basically all these national databases, they're often self-reported data. And compared to a well-run urology practice, I personally think those data sets underestimate the value of a urologist. It is something that most of us are not talking about. It is not being shown to the public, but a well-run practice, your production is going to greatly exceed what is publicly shared among these databases and data sources, if you will. And I'm not going to name any names, but you get the drift. As part of your contract negotiations, you want to consider in your contract cost of living adjustments, because inflation's going up, cost of living constantly goes up. At the time of this recording, you are living it. Inflation has affected the cost of goods that you purchase. So if your cost to live goes up, shouldn't you build in a cost of living adjustment in your contracts? This is applicable whether you're contracting with a private group or if you're contracting with health insurance, okay? Also in your contract, you want to think about, is your medical malpractice insurance included in that contract in your payment model? What about health insurance, disability insurance? How much vacation time will you get? What about educational meeting stipends? What about maternity or paternity leave? How is that calculated? Now, MGMA, Medscape, Doximity, they all have information regarding some contracting and terms of negotiation, if you will. Also, how much you are paid as a new urologist coming out of training versus a tenured urologist, someone who has been practicing for a while. That payment, that valuation may also vary. Okay. What else? You have to understand how you are going to be paid. And for the new urologist coming out of training, kind of like how it was for me. When I first came out of training, I took a job. There was a guaranteed salary for the first 1, 2, or 3 years. But then sometimes it goes into production-based. And that's another reason why you really need to understand how coding and billing is done, because your production is based on your ability to appropriately code and maximally capture everything that you do. When it comes to contracting, you have to learn some of the legal jargon, such as tail coverage, own occupation insurance, and also you have to understand the implications of private equity, which is the activity is slowing down a little bit nowadays because money is getting hard to come by for private equity to buy you out. But you have to understand implications of private equity to you as a new associate versus someone who is an old dog, if you will, in the practice relative to private equity, because the implications are vastly different between these two groups. Other things to consider when it comes to negotiations: what about your ability to participate in ancillary revenue, such as surgery centers, in-office dispensing, shockwave lithotripsy, pathology, PCR, real estate, etc.? Those are all things that you want to consider when negotiating contracts. Number 3, how money works. Understanding how money works, how money flows, how insurance works, which is an absolute nightmare, complex topic. And that also ties into coding and billing, because so much of the coding and billing is relative to how a particular insurance company operates. Learning about how insurance works, private insurance, HMO, PPO. In California, there's a large group of IPAs, or independent practice associations, where a bunch of physicians get together and contract with insurance companies so you can get better terms, more favorable terms. PPO insurance is different than HMO. And what about a professional service agreement, also known as a PSA? Not the other kind of PSA, but professional service agreement. A professional practice, a urology practice, can contract directly with a hospital or hospitals to provide a particular line of service. And for that, you are paid a certain amount of money. That is happening all across the country. Learning about how money works also involves talking to your billing and coding staff and office administrator. So you know the big picture. They are often great sources of information to help you understand the complex world of coding, billing, and insurance, and how money works. Understanding your compensation model. For instance, are you salaried or salary plus production after you hit a certain threshold relative to work RVUs? And here we are again talking about coding and billing. Are you paid with a hybrid model? For instance, everybody is paid based on work RVU, but the multiplier or the conversion factor differs depending on what you do. We all know, some of us know, that unfortunately hospital is nothing but an expensive hobby. Operating room is nothing but an expensive hobby. Some urologists who are really, really good at doing robotic prostatectomies, if they're stuck in the OR all the time, their production, their work RVU production, is not going to be as high as someone who does a lot of procedures and see patients in the office. They're not going to be as efficient. So should those robotic prostatectomists be punished because they are really good at doing robotic prostatectomies? Well, in a group practice, you may want to consider a multiplier. For instance, robotic surgeons may get a 1.1x of their work RVU production versus someone in the office who may take a slight decrease in the work RVU production. And then those numbers are then multiplied by a conversion factor to kind of not undervalue, but also recognize the folks who do surgeries in the operating room versus the folks who see patients in the office, just so that everybody is going to be happy. So that's a hybrid model, if you will. What about bonus based on production or per patient satisfaction? How is that done? It's important to understand these concepts when you are first starting practice. Will there be a penalty if you don't meet certain metrics of patient satisfaction, of production? What about profit sharing? What kind of value-based risk models is your practice in, or is the new practice that you consider joining in? How are the work RVUs tracked? This is something really important in hospital-employed models, because hospitals sometimes will downcode your services on their own without letting you know. In addition, they're pretty darn good at sometimes leaving your production and not tracking that. So I think it'll be really, really smart if you keep track of your production, your work RVU production on your own, in addition to trusting somebody else to keep track of your production. Also, when you understand coding and billing, you also will negotiate in your contracts how unlisted CPT codes, work RVUs, are attributed. If you do a procedure that is not the standard CPT, doesn't fit the standard CPT code, then you have to code and bill based on an unlisted code. There is a value attributed to unlisted codes, and certainly there's a value for the work that you do when you perform the unlisted procedure. How are those values, how is the production from performing those procedures calculated and kept track of? So make sure you're not losing out on that. What about compensation changes or increases over time? What about, very importantly, overhead allocation? So your gross revenue minus your overhead is what you get paid, the bottom line. So how is that overhead allocated? Is it equally among everyone? Doesn't matter how many days you actually work? Or is there some sort of varying valuation, varying attribution of overhead? Learning how to read a profit and loss statement in your routine meetings, in your partner meetings, that's important. Learning how to read a cash flow statement. What are the sources of revenue? And also, how efficient is the revenue cycle management in your practice, in the practice that you are about to join? Those are all some of the things that you need to consider when it comes to money and money flow. Okay, number 4, how to deal with hospitals. Yes, it is an expensive hobby. How do you deal with emergency rooms, hospital call? How many hospitals are you covering? Are you being compensated for taking the hospital call? Is the practice being compensated for you taking the hospital call? There should be compensation for taking ER call. And what are the expectations by the hospital whenever you are a member of the hospital? Do hospitalists admit patients primarily, and then you act as a consultant? What about OR block time? As a new urologist, you may not get the ideal block time. You may be allocated to Fridays after 12 p.m. Not the ideal block time, right? So you need to figure out what kind of block time opportunities do you have. When I first started practice, I had the ability to dictate what kind of equipment I wanted. So I brought in brand new laser, brand new ureteroscopes. Do you have that choice? Do you have the option? Is that in the contract negotiations? So that's something else that you need to consider when you're dealing with hospitals, making sure that you have the equipment that you need so you can be maximally efficient. And of course, you want to get to know the staff at the hospital, maybe the committees, participate in those committees so you can affect change. Instead of being told what to do, you can make the rules so that you can affect how things are done. Lastly, and I agree with Dr. Kaplan, that work-life balance is a myth. And I'll say this again, work-life balance is a myth. Stable work-life balance is virtually impossible to achieve. There's always going to be some chaos in your practice, in the hospital, in your life. And that is the norm. However, that said, you can specifically shape fashion your practice to strike that balance as best as possible. Ask me how I know. Learning to say no by setting boundaries is extremely important. Learning to set priorities. So I tell urologists and fellow practitioners, the number one thing you need to do is know yourself. You have to know yourself so you can set priorities, knowing what are important things to you and never compromise on that. And I tell patients actually and other fellow practitioners that if you're not healthy, you won't be able to take care of other people. You have to make sure you are healthy first. Just as when you're flying on an airplane, they give you the instruction in the event of a sudden cabin loss of pressure, oxygen masks will drop down. And what do they tell you to do? Put on your mask first before you try to put it on your kids or somebody else. Put on your oxygen mask first, okay? Same thing with life. You have to take care of yourself before you can take care of others. You have to take care of yourself as a physician before you can take care of your staff and also your patients. Developing some healthy coping mechanisms. And no, I'm not talking about alcohol or drugs. We're talking about outside hobbies. We're talking about maybe exercise or doing things that you enjoy doing outside of medicine, outside of urology. Kind of like what I'm doing right now. I love doing this kind of stuff, sharing what I know regarding the practice of medicine, practice of urology, coding, and billing. This is outside of urology. This is peripherally related to urology, but it's outside of urology. So finding things that fuel your passion, drive you to do things even if you're not getting paid to do it. So finding those things, coping mechanisms. That could be yoga. That could be meditation. That could be exercise. That could be spending time with your kids. It could be reading a book, making podcasts, participating in podcasts, learning about other things, woodworking, for whatever it may be. As I'm getting older, I'm thinking, what about my retirement? And I will tell you, learning from my patients, learning from other people who have retired, you must have a passion for something else. That could be your family. It could be some hobby. You have to have a hobby. Otherwise, you're going to be bored and you're going to stop working and then you're going to diminish. So you don't want to do that. You want to have some hobbies now as you're working so that when you retire, you'll continue a meaningful existence. Your partner and family, in my opinion, they're the most important thing. You will need their support during these chaotic times. And also, sometimes we're humans and we get sick. It could be just a flu, or for me, I had a serious health episode a couple of years ago. You will need their support during these chaotic times and uncertain, unpredictable times. So those are all important things. Doesn't matter how long you've been in practice, taking calls still sucks. Okay, that work-life balance, just you can throw that out the window. Call still sucks, and yes, some ER and hospital floor staff remain morons, and I'm just going to leave it at that. Granted, there are really awesome folks, but unfortunately, some are just not very commonsensical, if you will. So work-life balance, it's a myth. You can craft your practice the way you want to. You don't have to say yes to everyone. Knowing your boundaries, learning to say no, very, very important. I'll conclude with this. Urology residency may be tough. Starting to work as a urologist is truly just the beginning. You have a long career ahead of you. Make sure you learn about and master the tips above for a successful and happy practice career. As always, I welcome any comments, suggestions, agreements, and especially disagreements. Please leave them below. Thank you so much for the privilege of your time. Please take care of yourself and each other. Bye-bye.